حياكم الله في حلقة جديدة من بودكاست فوتون. معكم أختكم دكتورة شيخة العبيدلي. اليوم معانا ضيف مميز جدا دكتور مهش، رئيس الجمعية الأمريكية للفيزياء في الطب. Dr. Mahesh is a medical physicist and a professor in cardiology and radiology in Johns Hopkins University School of Medicine, and he is the current president of the American Association of Physics in Medicine. Dr. Mahesh has a lot of contribution in CT imaging, especially in developing of the multi-slice detectors and in the dose optimization of CT. We are pleased to have you, Dr. Mahesh, and welcome to Kuwait. You are here as part of the MIFOM conference, which is the third in the Middle East that we are hosting in Kuwait, and we are honored and pleased to have you visit us and be one of the speakers, especially with your experience in the diagnostic radiology physics. Welcome.
Thank you very much, and it's my pleasure, and also it's an honor for me to have this opportunity to come here when Middle East Federation of Medical Physics invited me, Dr. Meshari and Hassan. I know them for a while, and they invited me. I could not say no. It's like an opportunity. So I'm also glad that I'm able to meet with you and your colleagues here. So.
We are happy to have you. And we just want to ask about how you ended up in radiology medical physics.
Yeah. It's kind of interesting because nowadays it's much more straightforward. You have a medical physics program, you go there. When I was in grad school, I did not know about medical physics. I was in pure physics, intending to go and do my PhD in astrophysics. Then I went to a open house in Medical College of Wisconsin. And when I saw that, I was really impressed with the application side of physics. And then I applied and I got a fellowship to do my PhD. So once I started doing, it was really kind of nice because first year I did not know what I was doing because my advisor was based in the hospital. So I was given an office in the hospital. And first year I was also searching myself, what is a physicist doing in the hospital?
Yes.
But as we go along, I learned what I can learn and contribute. And that few years working in the hospital towards my PhD really made exciting aspect. So that led to this career of medical physics.
Yes. So how do you think the role of the medical physics or the medical physicist in radiology or diagnostic imaging has evolved from back in the days to now?
It has improved, but it's still a lot more to be improved. I'll tell you why. Because if you look at the, right now I represent the AAPM, the membership of the AAPM is 75% is radiation therapy. Because the radiation therapy centers has established that medical physicists are part of the parcel because they can bill their services to the hospitals and insurance. Because of that, also for the quality control required, they're here. Whereas in radiology, what happens is like, unless you have a bigger center, you can't hire a full-time diagnostic physicist. It's not cost effective. So what happened is like right now over the period of years, especially in the US, there was some regulation was passed. One of the big law was like, the Mammography Quality Standard Act was passed in 1994. When that passed, what happened is at the beginning itself, they made sure that every mammographic unit is evaluated by a medical physicist annually. And a radiologist who has a special training and the technologist. That kind of led a baseline for diagnostic imaging physicists. So right now in the US, any mammography machine has to be tested by a qualified medical physicist, which means he or she has to meet some certain criteria. That model worked out very well. And then in 2008, there's another act passed. And I was part of the American College of Radiology who advocated for this one. It opened up, what happened is basically the act tell every advanced imaging, PET, CT, and MR has in the outpatient center has to be evaluated by a medical physicist annually. That further opened up the strength and the opportunities. And that happened after a few months. Then there is other accrediting body to it's not just outpatient center. Everywhere they had to test. That opened up more job. However, still there is no need for more opportunities because, as I said, a small imaging center cannot hire a full-time medical physicist. Whereas a small cancer center, even if they have one LINAC, they can hire a medical physicist. Whereas in diagnostic imaging, if it is a small center, they hire a consultant physicist. And in imaging, that has been in the case in the US. Lot of these private hospitals, they want to satisfy these requirements, so they hire a consulting group. That consulting group of medical physics has grown because of this regulation. But big centers like Johns Hopkins or MGH or Harvard or Mayo, where there are a lot more research and teaching involved, that's very more economical to hire a medical physicist. At Hopkins, we also do a lot of research along with it. So that also coming together. So we are part of the clinical work, plus we also do research. That combination is one. So one of the forward ways, like we want to establish to the essence of the diagnostic imaging physics more. Because outside also within US even outside, not many places have diagnostic imaging concept. But we hear a lot about CT imaging. When you see CT imaging and all those things, that needs to be tested and optimized everything. And that role is there, but it has to be made as a requirement. Or that's the idea.
Do you think because it's not a requirement, it's mostly because it's not cost effective? Or do you think there's a lack of knowledge about the role of the medical physicist in radiology? As you said, most of the people know what the radiotherapy physicists do, where they know or does, or what the nuclear medicine physicist does. But when it comes to radiology, it's more ambiguous, maybe?
You are absolutely right. Actually, I'll take even further step. If you ask a general public who is a radiologist, a lot of them don't know who the radiologist is.
Yeah.
The reason is a lot of the radiologists are reading images in the dark room. They don't have a direct interaction with the patient, and that has been a negative for them. And now here comes medical physicists who also work behind the scene.
Yeah.
So he or she is there to help and certify the machine and accept as testing. Afterwards, it's not there on a daily basis. He or she. That is should not. We need more interaction. Like in radiation therapy, the radiation oncologist come down, look at the treatment planning. He or she talks with the physicist. So there's a direct. They recognize the value of the physicist more.
We're trying to stop that. The direct connection.
Direct connection. Yeah. So in imaging,
that's just a joke. We love the radiation oncologist.
I know you don't want to do that.
Yeah.
But in imaging, we want to do that. But it's not that easy because
Yes.
even though radiologists also take the physics exam in US, they have to pass the boards in physics. So a lot of them after they pass, they forget. So that is we want to change that.
Yes.
So it's more like we are trying to establish. It's like a teamwork, and that's still there more work to be done. That's why we have. It all depends on the leadership also in the bigger hospitals to recognize. But it's a requirement to some extent helps.
Yes.
So.
Do you think as your role as the president of the AAPM that you can have some kind of say on what regulations or what kind of laws that can be passed?
So that is one thing. That's where I think the professional societies, not just me as a president, but as a professional society, we encourage our members to work with the local regulators.
Yeah.
And in US, we have a good relationship. AAPM has a good relationship with the radiation protection directors in different states. They have like their own society called Conference of Radiation Protection Director. So we work with them very closely. Some of us are I currently, for example, in the state of Maryland, I'm on the advisory board for the Radiation Control Board. That helps because when they are making a new regulation, they will come and seek our advice. If we are not there to give the advice, and then it becomes the law, we can't complain.
Yes.
I would rather advocate as an AAPM member, we strongly advocate that working relationship with the regulators, with the policymakers. Even before it makes, if we can channelize, we don't have to, we know the knowledge, but we don't have to be selfish, but we can at least fine tune in a way which can help the patient. And that's one of the things which we are doing very strongly. In fact, this year as a president, one of my theme is, as I said, coming together to forge ahead. Among that, I strongly support advocacy. Because a lot of the time when you say advocacy, people are like, oh, you are a scientist, why are you doing political stuff?
Yes.
People forget about it. Like, for example, today morning when you have your health ministry,
Yes.
if you don't work with him, how will he know who you are?
Of course.
But since you know him and he knows your work, if there's a new law comes or a cancer center opens, he automatically will recognize there is a need for medical physicists.
Yes.
And that purely happened because of the advocacy. And I'm a strong believer of that science and advocacy.
Yes.
In fact, I was at the forefront when we had that Hopkins, we had the first PET-CT back in 2001.
Oh, wow.
So we got the first images done,
Yes.
and then within hours we were to publish in the SNMI. We got our nuclear medicine physician was very happy. Then what happened? Within a year, the government started reimbursing very strongly because one of the inventor was a good friend of the politicians, advocates, and some of the politicians also got PET-CT, so they saw the value of that one.
Yes.
Then immediately they increased. That's one example. The other one is cardiac CT. So cardiac CT, we were at Hopkins, we had developed from the beginning one cardiac CT imaging from the 4 slice to 3. It's really a lot of work, very nice. And now the cardiologist, for example, in 10 years, even 10, 15 years ago, if the patient goes to emergency room with a chest pain, majority of the time they will send to cath procedure, which is a very invasive, or they will go to open heart surgery. Now the studies have shown that you can do a cardiac CT exam in the emergency room. And if the study shows negative, they can actually send the patient home.
Oh, wow.
Look at how the complex, and parallelly we have worked together in reducing the radiation dose. Meanwhile, when some of these the administrators and the senators in the US recognized that value because they had cardiac CT, now that was reimbursed. So what I meant to say is like the advocating for our science is very important. Like example here, what you're doing, that relationship you establish with your regulators
Yes.
and with the Ministry of Health,
Yes.
you need to cultivate and grow stronger because that is very essential for medical physics growth.
So you think this is what we should focus on in countries in such a medical physics is not recognized? Yeah.
In fact, that's very true. Actually, one of the things which IOMP or AAPM, from long time, we used to do this long time back, and AAPM had a program to this 1 week workshop in LMIC countries, in radiation therapy workshop and also diagnostic imaging workshop. I was chair of the diagnostic imaging, so I used to do this different workshop. The purpose there is not to show off that you know more.
Yes.
The purpose was to go to these countries and help the local physicists elevate their presence in their local community, especially the radiologist and the physician community, the value. So that way they recognize the value of the medical physicist, and that becomes regulation. One example I'll tell you. In the US, actually, the Bureau of Statistics, labor statistics is a big thing, where they keep a survey of all the labors of different codes.
Yeah.
Medical physics is not there right now.
Yes.
So this year we applied it to be included as part of the labor recognition. That way 10 years from now we'll have a lot of data official. I think that's what is needed. We need to work parallelly along with our work. We need to keep an eye on this, working with the regulators for new policy. Other one is advocating for this recognition part in the labor statistics. Europe has done a much better job. They have part of this European regulation.
Yes.
Lot of the time we complain regulation, but sometimes regulation also help us.
Of course.
How you do it, that's it.
Yes. Because I was just talking to Dr. Daniel Berger just before you.
Yes.
And we talked about how much the regulation has affected maybe the innovation. But at the same time, the regulation helps with recognizing fields and maybe pushing the field forward.
That's very true. And that's where the regulators, when the scientists or the medical physicists such as ourselves, we work with these regulators and they recognize our value. It is really opens up. I'll tell you another example. A few years ago, the NRC, the Nuclear Regulatory Commission in the US, it regulates everything with respect to radiation, including medical radiation.
Yes.
And the new commissioner is appointed by the president. And that person, they were starting to write new regulation for cyclotron.
Yes.
And I'm glad they reached out to AAPM that they want to see a visiting cyclotron. And the AAPM reached out to me whether they could come to Hopkins.
Yes.
We are close in the DCs. I told fine. Then I went to my chairman and they were alarmed. Oh my God, NRC is coming, so we don't want,
Yes, of course.
And I told them this is a plus side because the regulators are coming to see what we are doing, which means we are in a friendly environment. So they came and visited. We had we had a visit, a whole day visit. And then they took some of our advice and took part of us as a writing scheme for this regulation. I think that formulation is behind the scene working. It's really important.
Yes. So of course you've been in the field for a long time. Yes. So do you remember the time before all these regulations and before the recognition of the medical physics field? So do you think that the regulations and the recognizing of the medical physics field has helped in reducing the incidents caused by radiation?
Yes. I'll tell you why. I'm not that old when until no, just to be clear. I'm just kidding. But I've seen many. One example I'll tell you.
Yeah.
This was unfortunate incident back in 2009, 2006 or 7. There was a big report which NCRP published on radiation exposure to the US population. I was part of the committee, one of the member of the committee. We published this report, which was an updated of a previous report was published in 1982. So we knew medical exposure is in higher.
Yes.
Imaging part. I'm not talking about radiation. So, but the headline news was, it increased from 0.5 millisievert to 3 millisievert across the US population. That's the formulation. The way the headline read was, US patients are getting 600% more radiation now.
Oh, wow.
Imagine the perception it throws. Media, the way they did a calculation, 0.5 and 3 is 600%. They're like, the radiation exposure to US population is increased by 600%. So FDA had a hearing, Congress had a hearing. Along with it, that actually helped for the vendors to innovate new things and the medical physicists to look more closely into how to optimize it. Radiologists started paying attention. Now the radiation doses per patient has gone down. But one incident was really bad. What happened is, like in 2009, there was a series of patients came with a hair loss. It happened in a very prime institution. And upon investigation, we found out, the CT perfusion was new modality, and somebody without the knowledge of the involvement changed the technique. So they were in a way trying to improve the image quality, or they reduce the radiation dose, but instead they asked the system to produce 8 times more dose. So all these 300 patients came with a classic hair loss. It was in the New York Times front line. We knew that it was a mistake. But that led to some of the regulation. So then what happened is, like in state of California, immediately they required the radiologist had to put the dose information in the patient record. So the governors, Arnold Schwarzenegger was the governor at that time. That was the last bill has to be passed. So he called, who did he call? He called the regulators in California. And regulators immediately called 2 of my colleagues. So 2 of my colleagues were medical physicists, were experts in the field. They drove to Sacramento. They wrote the law in the afternoon, drafted. By evening, it became a law. What I try to highlight is that connection, if you're not there, the regulators, if they didn't have this connection, they would have written something else. It can be even more archaic or something.
Yes.
But it worked out such a that my colleagues were ready to dry down, sat down and wrote it out, and immediately it wrote like, and so that is the relationship which we see really important working.
Thank you, Dr. Mahesh. Of course, we cannot talk about radiology without talking about AI.
Of course.
It is, I think, and correct me if I'm wrong, that AI made huge impact on especially diagnostic radiology nowadays. Yeah.
So I'll tell you one thing. If you look at the US FDA website, there are nearly 1,000 companies have been approved, tools have been approved. Out of that, almost 700 are in radiology related one. But I also want to clear is, like, none of them are approved as a diagnosis method. None of them are there as to replace the radiologist. They have helped for triaging tools, for workflow, which is really found very useful. For example, emergency room, a lot of patients come and the radiologist sitting there and reading the images constantly. Now if they have these tools, it'll automatically highlights which has to be read immediately.
Yes.
Somebody is there may be a stroke happening, they can read and send back to the clinic. I think those tools are going to be really helpful.
Yes.
So AI, right now, there are a couple of things. One is, it's going to help it should support to help. It's not going to replace radiologists. It's going to help. Second thing is, it should make our life a little bit more easier. For example, radiologists spend a lot of time writing the report.
Yes.
And right now, the reports are really difficult to read. If you see a radiologist report, it's so difficult to read because it doesn't make sense. They tell about 50 different things, no, and finally this is suspicious, call back.
Yes.
So they can summarize it in one sentence. This is what you come for the patient, yes or no, go home, or something like that.
Yes.
But anyway, they're asking for a structured report. So there are a lot of companies that are trying to see whether radiology reporting can be done by an AI tool and then corrected by the... so there are a number of these things are happening. But at the same time, there are a lot of tools have been generated for diagnosing better everything, but it needs some more time. And that's where that evaluation, and I personally feel that's where we medical physicists can participate in developing QA tools.
Yes.
Even in radiation therapy or in AI, in imaging. And then that's why the AAPM, we are trying to do clinical boot camp to bring awareness of the AI to the next level. Not that we want to train everybody as an AI expert. I'm not an AI expert and I won't be an AI expert. But as a user of AI, I need to know what questions to ask.
Of course.
That is important. And right now, we cannot ask what question to ask if we don't know the basic aspect. We don't know the terminology. So that's what we want to prepare ourselves.
Do you think people are more accepting of AI nowadays than before?
So yes, I'll tell you why. Because there was a survey done, is in a publication actually, in Europe. They had surveyed the medical physicists, asking simple questions. And two questions really caught my eyes. One was, what is your knowledge of AI?
Yes.
And majority were selling is no took maybe 70%. Only 5% was expert. I think probably they are AI researcher. The next question is like, do you like to know more about it? Majority said, I would love to learn more about it. I don't know, but I would love to learn. That means there is an acceptance.
Yes.
And they know that I need to learn. But the way to learn is, that's where the professional societies can help.
Definitely.
These type of workshop and training can make a difference to awareness. So
definitely. So Dr. Mahesh, if you can give an advice to say the young physicist just starting in the field of medical physics, what would it be?
One word, be curious.
Great.
That applies to everybody. The reason is like, especially youngsters early career, they need to be curious not only in their field, but what's happening around.
Yes.
When you know what's happening around in your field, then you can focus more and appreciate what you're happening. That's one thing. Second thing is, especially youngsters, I tell like, in the real estate market, you say location. You say, in our field, it's the literature. You have to keep up with the literature. What's been published, what's coming out. Compared to when I was graduate school to now, it's much easier. When I was in grad school, I had to go to the library, through the index card, search for the article. Today, I can subscribe to 10 different journals. Not get the articles, at least I can subscribe freely the table of contents.
Yes.
So every month I get a table of content from all these journals. I can screen through the table of contents and I can leave an article of my interest, I can either read it more. I think that should become like a habit. The time they spend on Instagram, the same amount of time if they spend on literature, and that can increase the value. And that's also one of the reasons why I share a good article on Instagram.
Yes.
That's the pure reason.
Yes, actually, I'm a fan of Instagram.
Yes. And I'd like, because we are all busy with everything.
Yes.
And one image and summary of this, we tweet it and it goes out and somebody say like, oh, and if they're curious, they might like it.
Yes.
Even otherwise, what's happening? That's what I would encourage the youngsters.
Yes.
And then again, the other thing is for youngsters is, right now it's opportunity, because compared to when I was growing to the class, now we have these professional societies.
Yes.
We are making an effort to help them. I would advise them to take advantage of that.
Yes.
And connect with people and learn how to communicate, and they can find pathways. So now, for example, AAPM has a mentorship program, global mentorship program. So we identify the applicants and we create a mentorship program where the mentees are in the LMIC country, but the professor may be in the US, and we connect it. So they have done project together. So sometimes they even come and work there.
Yes.
So those type of things, I want youngsters to utilize it.
I think that's actually great advice. Thank you so much, Dr. Mahesh, and welcome again to Kuwait. It's actually an honor to have you in this podcast.
Yes.
Thank you.
You're welcome.